Well, welcome everybody. It is my distinct honor to get to introduce Dr. Rao, Vikram Rao. And Dr. Rao attended UC Berkeley for his undergraduate studies in neurobiology before earning his MD and PhD in biomedical sciences from UCSF. He completed a neurology residency at the Brigham and Women's Massachusetts General Hospital in Boston, serving as chief resident in his final year. He returned to UCA San Francisco for fellowship training in epilepsy and joined the faculty in 2014. He is currently an associate professor of clinical neurology, Ernest Gallo Distinguished Professor, and chief of the epilepsy division in the Department of Neurology. His clinical and research interests involve applications of neurostimulation, device for drug-resistant epilepsy, neuropsychiatric disorders, and seizure forecasting. I forgot to mention that my name is Mark Summer. I'm with SK Life Science. We're one of the sponsors here at the event. Okay, thank you very much. Dr. Rao.
Thanks, Mark. I've been advised to lean forward into the mic so that people can hear, so it's not that I have bad posture, it's that I'm trying to lean forward into the microphone. It's really nice to be here. It's my first time at the event at Disneyland here, so it's really an honor and a privilege for me to meet a lot of people who live with epilepsy, to learn from them, and to be with all of you to share ideas, so thank you for having me. We're going to talk today about a topic that's really near and dear to my heart, which is the concept of seizure forecasting, which is, as you'll see, similar to weather forecasting. If you were in the session immediately before this one, there was a woman who is the mother of a person who lives with epilepsy, and she was saying how one of the hardest things is just not knowing when the next seizure is going to happen. And that is a very sobering thing to hear, but it is actually exactly the motivation for everything we're going to talk about today. So these are my disclosures, nothing particularly relevant. I like to start here. It is difficult to make predictions, especially about the future. So depending on what you read, this quote either comes from Mark Twain, Niels Bohr, or Yogi Berra. But it is actually probably a Danish proverb. And this is really our challenge, is we are going to try and make predictions about when the next seizure is going to occur. This is our roadmap. We'll start with a brief introduction. I won't belabor, but we're going to talk a little bit about the history of efforts to explain the timing of seizures. We're going to talk about some technology and some advances in chronic EEG. We're going to talk about the concept of cycles. I'm going to try and convince you that epilepsy is a cyclical disorder. We'll talk about seizure risk or likelihood of seizures, and then seizure forecasting. I'm going to describe two different approaches we've taken to this problem, and then we'll wrap up with some future directions. So just by way of introduction, let me tell you some things that you already know. You know that seizures occur suddenly. They tend to be stereotyped, which means that they're more or less similar from one to the next. And I say that almost anything the brain can do, a seizure can look like. Epilepsy just means having recurrent seizures, and as we all know, it is all too common, fourth most common among neurological conditions. Only migraine, stroke, and Alzheimer's disease are more common. It affects about 1% of the population, and the lifetime prevalence is 1 in 26. Almost anything that is harmful for the brain can result in seizures. There's a long list there. Seizures can also be cryptogenic, which is doctor speak for we don't know. That happens a lot also. If you came to my colleague Dr. Klein's talk earlier this afternoon, you saw really cool videos like this. And he told us a lot about the technology that makes this work and helps us visualize seizures. But when I look at a video like that, what I think is, wow, seizures can come out of nowhere. The brain activity looks totally normal in one moment, and then it's like on fire in the next moment. How is that? How can we anticipate that? We know that epilepsy is a lot more than just seizures. I made this slide to sort of highlight the fact that it's really just one of many things that our patients must grapple with. And if you think about it in one sense, even people who have very frequent seizures, the fraction of total time spent having a seizure is generally very small, maybe 0.05% of the time you're actually having a seizure. So the problem is not that people are seizing all the time, it's that they could seize at any time. And it's that unpredictability of not knowing when the next shoe is going to drop that can be the source of a lot of disability, and that is not my idea. This is what our patients tell us. This is a survey that was done by the Epilepsy Foundation. It's a complicated graph. I'll summarize it for you. This was a one-question survey, super easy. Of all the things that are bad about having epilepsy, what's the worst? And there's a lot of different things on here, as you would imagine. Number one answer, worst thing about epilepsy, unpredictability. We've done our own work on this. This is work from one of my colleagues, Sharon Chang at UCSF, who looked at factors that impact quality of life for people who live with epilepsy. On the y-axis is people with relatively low seizure frequency, on the x-axis, relatively high seizure frequency, and the only factor that came up as being most important for both categories of patients was seizure unpredictability. So lots of things determine quality of life, but seizure unpredictability is a big one. And this can be disabling. This concept of not knowing when the next seizure may strike, this is really what we want to try and address, because when my patient asks me, is my next seizure going to be in 5 minutes from now, or 5 days from now, or 5 weeks from now? Honestly, I just shrug my shoulders. I really don't know. And that feels terrible for me, and it feels even worse for them. This is a paradigm that's going to feel very familiar for many of you. Tell me if you've seen this before. You go to your epileptologist, you do the best you can describing recent seizures, maybe you keep a diary of recent events that have happened, maybe it's on your phone, and your provider says, okay, well that looks pretty random, sorry you're having seizures, so let's do this. Let's pile on a bunch of medicine, and you're going to take that twice a day, every day. So essentially what they, and by they I mean me, is offering is a static treatment for what we know full well is a very dynamic disorder. And it is probably not true that seizures are equally likely to occur at every moment of every day. We kind of know that that is not true. And yet, what do? 600 milligrams twice a day of medicine X. That's my solution. That is not great. And that is why history has seen many attempts for people to explain why seizures occur when they occur. Let's review some of this. It's kind of fun to take a journey back now, hundreds of years actually. The Babylonians recognized that people who had epilepsy, even in those times, that some people had seizures during the day and some had seizures at night. This tablet that you see is the so-called tablet 26, which is cuneiform script, which apparently, according to my deep internet research, says that some people tend to have seizures after they awaken in the morning, and some people only have seizures at nighttime. So as far ago as that, it was recognized that seizures are not random. The Greeks thought that seizures are controlled by Selene, who is the goddess of the moon. And boy, that was a tenacious idea that there's a lunar influence in epilepsy. In Roman times, Pliny the Elder said the full moon caused the brain to become unnaturally moist, and that is what led to epileptic attacks. So there you go. That was the prevailing wisdom. In Roman times, in the Middle Ages, it was thought that the waxing moon heated the atmosphere, melted the brain, and that provoked seizures. Okay, so that's pretty vivid. Also lunar influence. And Richard Mead, who is an esteemed British physician in the 18th century, said, the moon's influence was so visible on people with epilepsy at the new and full that I have often predicted the times of seizures with tolerable certainty. So he was quite convinced that to understand the timing of seizures, one needs only to understand the moon. We are going to come back to that in a moment. Let's talk about this person. This is Sir William Richard Gowers, who some say was maybe the best neurologist of all time. He practiced in the late 1800s, and he, like the Babylonians many years before him, recognized that seizures are not random, and he had a classification scheme which was simple. He said, well, some people have diurnal seizures, which means seizures during the day. Some people had nocturnal seizures, seizures at night, and some were diffused. That was his term, which means they could have seizures at any time. Fast forward now, 1929. This is work by Mary Langdon Down and Russell Brain, who followed 66 people with epilepsy for 6 months, and they recorded over 2,500 seizures, and then they plotted on a time scale when those seizures tended to occur. And you can see at the top of the graph that some people tended to have seizures kind of in the late night or the early morning hours, some only at nighttime, the nocturnal cases, then some diurnal shortly after awakening, and some people, like the bottom panel, kind of had seizures spread throughout the day. So these correspond more or less to what Gowers described: diurnal, nocturnal, diffused. Okay, that's nice. Now let's go forward 10 more years, 1938. This is a paper published in The Lancet by Griffiths and Fox. These were the medical superintendents of a place called the Lingfield Colony, and this sort of an unfortunate place in the south of England where 110 mostly young women, some young men, were resided, essentially, and all of them had epilepsy. And over a 10-year period, Griffiths and Fox wrote down every seizure that every one of those people had. And what they noticed was that many people had these curious patterns. They had seizures that kind of came in a flurry every week, every couple of weeks, every month. And by the way, this was male and female patients. And they had no explanation for this. They called this rhythm in epilepsy, but they really, to borrow an analogy from Dr. Kleen, they had no way to look under the hood and see what was actually causing this or to leverage this in any way. It was just a phenomenological observation. People have these weekly and monthly patterns. Nowadays, we rely on patient self-reports or diaries that people keep of their own seizures. And being from the Bay Area, we have a lot of tech people up there, and they keep spreadsheets and fancy ways of tracking seizures, which I appreciate because I like looking at graphs. But sometimes we can really see monthly patterns, weekly patterns. Sometimes people use a good old-fashioned calendar and write down, for example, the association of seizures with menstrual periods. This is a picture from one of my patients' seizure diary showing that relationship. So I think that for years, patients have told me in my clinic, I have seizures every 14 days. I have seizures every 45 days. And I just believe people. I mean, I never know what, I never really knew what to make of that. How common is this? Is that true, first of all? And if so, how does that work? And I don't know if I'm going to answer all of those questions today, but I'll tell you what we've done to try. The biggest eye-opening thing was the advent of what's called chronic EEG. Chronic just means long-term. And to sort of show you why chronic EEG can be so helpful if you're studying a periodic phenomenon, let's look at this. So I made up this signal. This is not actually any real data. This is just a squiggly line. But let's say you wanted to study this squiggly line. You want to understand those component oscillations that are so obvious. And what you did was you did a very short study. You did a 30-minute outpatient routine EEG. So there's your window inside that green box. That's what you can see of the signal. Well, if you just saw that, I don't think you'd really notice that it's cyclical at all. I think you'd just see a little snippet of brainwaves, and that'd be that. But maybe you brought somebody into the hospital for a few days in the epilepsy monitoring unit, and now you would say, look at that. There's actually this fast red oscillation. I can see that. Great. But only if you did a very long time scale study, chronic EEG, would you see that there is also this slower blue oscillation, which, by the way, has been there the whole time. It was technically even there in your 30-minute routine EEG. You just couldn't see it because you didn't have a wide enough temporal lens. Okay, so that is really the beauty of taking a kind of long view of a cyclical phenomenon. And all of the data I'm going to talk about today comes from one technology called the RNS system. And the reason that I'm going to focus on this is that this is the only FDA-approved technology now used in thousands of people that gives us access to an interpretable form of chronic EEG. So that is the reason why we're going to be talking about this device. Many of you have probably heard about this. This is made by a company called NeuroPace, but responsive neurostimulation is the name of this device. You can see it here. It comprises a neurostimulator that's implanted in the skull. It has 2 lead wires. Each of them have 4 electrode contacts at the ends, and those electrodes go inside the brain. We put them at the epicenter of the seizures. So where the seizures come from, that's where we put the tip of that wire. And the wire does 2 things. It helps us listen to brain waves so we can record brain activity, and it helps us deliver electrical pulses back to the epicenter to try and quiet seizures down over time. Here's a little animation of how that looks. So the device is continuously listening to brain waves. If it's normal, nothing happens. If it detects something abnormal, it delivers electrical stimulation to try and suppress seizures. So some people call this a pacemaker for the brain. I think that's a fine analogy, but this is really how it works. And it is approved by FDA as a therapeutic device. It's meant to reduce seizures over time, and it does do that. But in the course of normal use of this device, providers have access to a form of long-term data, a form of chronic EEG. And that means that as the device is listening to brain waves, it is actually storing snippets of those brain waves for providers to look at later. And it turns out this is a treasure trove of information. There's all kinds of data that are stored by this device that clinicians can look at. I tell people, when you get RNS, we hope that it will reduce your seizures, and for most people it does. But regardless, for almost everybody, we learn something about your epilepsy, and we learn because of all this data. So for example, we get snapshots of sparks between seizures. We call them interictal discharges. We get pictures of seizures themselves. Patients can force the device to store a recording when they feel something like an aura. We get trends and patterns. We can see responses to new medications that we start. Really a wealth of information. And there's a lot that you can do with this, and I definitely do not have time to talk about all of the different applications of this really precious data set. But I am going to focus on one of them, which is exactly what we talked about before, that wide temporal lens to study cyclical phenomena and look at temporal trends. So we're going to focus on that. Okay, let's drill down and talk about exactly what is being measured by this device. Two things at its core. One is it's listening for sparks. So you can think of discharges that happen between seizures as like seeing a pile of firewood, and it would be, if it's sparking, you would say, that looks like that could catch on fire, but you wouldn't call it a fire. So it's counting the rate of those sparks. And I'm going to call that interictal, that means between seizures, epileptiform, which means abnormal epileptic brain activity, IEA is my term for these sparks. So it's going to give us the rate of those sparks, and it's also going to count seizures. We use this jargon word called long episodes, but it basically just means that something's abnormal and it stays abnormal for a long time. That's usually a seizure. It's going to count those two. So it's going to count the rate of sparks and the number of seizures. Okay, why does that matter? It matters because it turns out those things are not the same all the time. This is data from one of my patients. Each row on this graph is 1 week of data, and it goes back over the last 12 weeks. And it's showing us how many sparks are happening in each hour of the day on average during that week. And this person actually goes to bed around 9 p.m., and he wakes up around 8 a.m. And you can see then that when he's asleep, lots of sparks. This is the most common pattern. Some people have an inverted pattern where sparks go away when they sleep, and they're more common during the daytime. We would call this circadian, or about daily cycle. Okay, well, that's pretty straightforward. What about this, though? This was one of the first things we saw when we started using RNS about 10 years ago. Here I'm showing data. This is about 1 year of data from a male patient and a female patient. And I have not adulterated this data in any way. This is straight off of the device. These are daily counts of sparks made by the device over about 1 year. So what jumps out at me when I look at this is that it's not the same every day. It looks like it kind of bounces around in a kind of cyclical manner in both a male patient and a female patient here. So what do we got to call these? Well, this is not circadian because these cycles are kind of about a month apart, so we call them multi-day or multidian cycles. So circadian cycles, the daily cycle, multidian cycles, multi-day cycles like this. We're going to be talking for the rest of the time about cyclical events, so it's worth having some terminology to be on the same page here. So let's say there's some event that you care about, that's the blue dot, and it occurs in relation to some underlying cycle, like this gray cycle here. I might say it's pretty clear that this event, at least in 2 instances, occurs on the upswing of that cycle. And so one way to depict that is with something called a polar plot. Sounds fancy. It's not really that fancy. It's a circle which represents one cycle of that wave, then another cycle, and there's an arrow on that plot, and the arrow points to the portion of that cycle where that event tends to occur. The longer the arrow is, the more tightly locked that event is to that phase of that cycle, the more it likes to occur at exactly that cycle. So the length of the arrow indicates the strength of that phase locking, and the direction is what portion of the cycle the event occurs on. All right, let's talk about cycles. So the first observation was that almost everybody has a circadian cycle, and almost everybody also has a multi-day or multidian cycle as well, and it's the same for men and women. We heard a great talk by Dr. Deng recently, just before this, on catamenial epilepsy, but this is not just catamenial epilepsy, because the distribution of these multi-day cycles in men is identical to women. So it can't just be catamenial epilepsy. Let's look at this complicated graph, but the colors help. So here we're looking at a polar plot. Each arrow is a different person. And the direction that that arrow points is the time of day when that person tends to have their seizures. And you can see it's kind of spread out, like people have seizures at all different times of day. But if you can use the colors, maybe you can see it's kind of clumped into 5 groups. There's sort of 3 preferential times during the day. We call them D1, D2, D3. And then there's a couple at night and 1 and 2. So Some people just have a predilection to have seizures at certain times of day. This is probably what Gowers would have called diurnal and nocturnal patients. This is the quantitative representation of that. People also have different types of multi-day cycles. So again, complicated graph, but if you look at the y-axis of those plots on the left, you'll see that some people have a peak cycle at around 7 days, some people at around 13 or 14 days, some people at 20 or 21 days, and some people 28 to 30 days. Curiously, they all tend to be multiples of 7. And I don't have a great explanation for that. There is no phenomenon in biology that actually oscillates on a 7-day cycle, and it is not as simple as the calendar week. We've looked. But this is what it is. Most people have multi-day cycles, and they tend to be some increment of 7 days. Interestingly, people also have longer cycles, and we call these circannual chronotypes. That means, and we've all heard, or maybe you know somebody, maybe you have experienced this yourself, seizures that tend to occur at a certain time of the year. For years, people have said, oh, well, I always have seizures at the end of the summer. Well, that is what it is. I never knew what to make of that, but now I know that about 12% of people actually have an identifiable circannual chronotype where they do tend to have seizures at a particular time of year, and it can be any time of the year. Each polar plot here is from a different person. So people can have seizures that vary annually, but here's the really remarkable thing. The remarkable thing is that a given person can have cycles operating over multiple time scales. So all the data on this slide that I'm going to show you is from one person. So this person has a clear annual variation in their seizures. So you can see that cycling. It has a peak at around 365 days, and this person tends to have their seizures, looks like late winter, early spring. So they have a circannual variation. But the same person, if we drill down on their data, has a multi-day cycle with a period length of around 30 days and a tendency for seizures to occur on the upswing of that 30-day cycle. And the same person, if I drill down to the scale of days, the black and white rectangles at the bottom strip are day, night, this person has an obvious circadian cycle and a preference for seizures to occur at around 6 p.m. So what does that mean? That means that what happens when it's late winter, early spring, they're on the upswing of their multi-day cycle, it's late evening around 6 p.m., that is when they're going to be at highest risk of having a seizure because all of those cyclical time risk factors are going to be in confluence. It's going to be aligned, okay? So this concept of alignment of cyclical risk factors is very important, and it's important that it is not the moon. We looked. Because people would raise their hand at a conference and say, but, what about the moon? And truth be told, the lunar phase is 29.5 days, and many people have a 28 or 29-day cycle, so we had to look. And this example at the top is very interesting. You can see, it might not project very well. You see the full moon that's highlighted in blue. A seizure is the red dot. That seizure did occur on the full moon. And once in a while, if you're somebody who has a 28-day cycle, your next seizure will occur on the next full moon. You can easily see why, historically, like we talked about, people sort of assume that maybe the moon has something to do with this. It's very easy to see how you would make that conclusion. But when you do the math, mercifully, it is not the moon. Thank God. I have never been happier in my career to have a negative result than this because I think I would have been laughed out of conferences if I said that it was the moon. It is definitely not the moon. But if you look at the lower left polar plot, you see that all those arrows do cluster very tightly in relation to the multi-day cycle. And in this case, they occur on that rising phase of the cycle. So we started thinking, well, if there's these cycles and people have seizures at certain times of those cycles, maybe where you are in a given cycle determines your risk of having a seizure at that moment, right? If you're at a time in your cycle when you don't typically have seizures, you're kind of at low seizure risk. But if you're at that peak time when your seizures tend to occur, you're at higher risk. So we started looking at this. This is the very first patient that we ever had at UCSF who had the RNS implanted. This was in 2014, and this individual has a 26-day cycle that's shown in orange. And this is how his seizures occur. That's in red dots. They tend to cluster on the rising phase of that cycle near the peak, but just before it. So that was for him. We started seeing this over and over again. This is data from another person. Clear multi-day cycles. Here the black dots show the seizures. The bigger the black dot is, the more seizures the person had at that time. And if you can kind of just look, just by eye, the seizures tend to occur on the upswing of these cycles. Very few seizures happening in the trough of the cycles, and also not that many happening at the peak. They tend to occur on the rising phase of the cycles, near the peak, but just before it. So that's interesting. So that means if you knew what somebody's cycle was, maybe I'm a 14-day person, let's say, and you could project that forward in time, and think about the next time you're going up on that cycle. Well, that would be the time when you're at highest risk of having a seizure. Maybe I could tell somebody that. Maybe that would help them to know when seizures are most likely to occur. This is a 50-year-old field. Seizure prediction goes back to the 1970s. And the number of papers, scientific papers that people have published on this topic has increased exponentially during that time. So a lot of people are very interested in this question. It's a very difficult problem. And most of that time has been focused on true prediction, which means, yes, you're going to have a seizure, or no, I predict you're not going to have a seizure, binary, right? But in recent years, we've pivoted a little bit as a field to a more probabilistic stance. There's no weatherman that says, it will rain tomorrow. That's not what people say. Meteorologist says, there's a 90% chance of rain tomorrow, right? They couch it in probabilistic terms because you can't actually know if it's going to rain tomorrow, but you can know that, all the factors are in alignment and whatever, barometric pressure and all that it's very likely to rain tomorrow. So we thought maybe we should be talking about probabilities of seizures. And by the way, we're all used to looking at probabilistic forecasts all the time anyways, aren't we? Before I came on a trip down here, I looked at my weather forecast app on my phone and said, is it going to rain in Southern California? And of course not, it never rains in Southern California, so probably not. But if it did, if it said 90% chance of rain, I might have done something differently. I might have packed an umbrella, for example. That would have made sense. And similarly, when we think about seizure forecasting, we think maybe if we had reliable forecasts, people could pack umbrellas. Maybe they could take more medicine, modify their behavior, alert friends and family. Maybe that would help. Let's see. But first we have to make reliable forecasts. This is what we did. So we said, all right, we have this rich data set from the clinical trials of RNS, 256 patients, 10 years, lots of data. Let's go back to that and let's take a portion of it and build some mathematical models that would look at the association of seizures and cycles, and let's train the models on that, and then show the models the rest of the data and ask the model to sort of forecast the likelihood of seizures on data that it had never seen. And let's ask how reliable that is. Well, it turns out this is not easy, because it is hard to evaluate a probabilistic forecast. Let me try to explain this. So let's say I have a weather forecasting model. Okay, here it is. Here's my model. And I take it to the desert. Now, my model is a particularly stupid model. Every single day, it says the chance of rain is 0%, no matter what. That's what my model does. And I take it to the desert. And I say, what's the chance of rain tomorrow? And the model says 0%. And tomorrow comes, and it doesn't rain. Well, is that a good model? I mean, it was right, nominally, right? But I would say no, this is a bad model, because rarely it does rain in the desert. And on that day, that model will say 0% and it'll be wrong. So it's not a good model, because it does not pick up those rare moments when it's something other than the most common outcome. And conversely, let's have a different model. I take it to the rainforest and I say, what's the chance of rain tomorrow? And the model says 90% chance of rain tomorrow. And tomorrow comes and it doesn't rain. Is that a bad model? I would say not necessarily, because when the chance of rain is 90%, 10% of the time it doesn't rain. So maybe that was just the 10%. So it turns out that evaluating probabilistic forecasts is pretty tricky. In fact, what we did is we delved into the meteorology literature, because meteorologists have sorted all this out many, many years ago, because this is what they do for a living. So we borrowed metrics from meteorology, like Breyer's skill score and a bunch of other complicated mathematical things, to try and evaluate forecasts. And basically, this is what we found. So this is just an example. This is a little too much detail probably, but the line at the top that turns red, that is the output of our forecasting model. And when it's red, that means high seizure risk. And at the bottom, all those dots, those are the actual seizures that a patient had. And you can see that when the model said the chance of seizure was high, sure enough, most seizures fell during that time. Once in a while, some seizures fell during a period when the risk was forecasted to be low. So, the models are not perfect. So overall, this is the summary of that study. Overall, if we tried to forecast one day in advance, we could do better than chance in about 2/3 of people. And 1/3 of people, we weren't even as good as chance, or we were at chance level. If we tried to forecast 1 hour before a seizure, we could do better than chance in everybody that we looked at. But again, that's only 1 hour horizon. So it's easier to say, is it going to rain an hour from now, than it is to say, is it going to rain 3 days from now? The longer your horizon is, the harder that problem becomes, right? So clearly, this was not the be-all, end-all of seizure forecasting. I mean, it was some initial effort. We made some inroads, but it's not perfect. And there's some big problems with this. So problem number one is that if you're going to do a cycle-based forecast where you're going to characterize somebody's cycle and then march it forward and then extrapolate and tell them when the next seizure is going to happen, you have to know what somebody's cycles at baseline are. which means you got to record them for months to see many instances of the cycle and say, okay, I see you're a 21-day person, got it. Well, that's not that easy to follow every single person for many months to characterize their cycles just because you want to issue a forecast, right? That does not feel scalable to like thousands of people, millions of people. Okay, that's problem number one. Problem number two is, if you build a perfect model for one person, there is no guarantee that that model will work for the next person. So do you have to make a custom model for every single individual? Wow, well, that doesn't also sound very scalable to millions of people either. And finally, if you use data, which people have done from wearable devices like Fitbits, Apple Watches, whatnot, that's great, and there is forecasting value in data from those devices too. The problem with the wearable is sometimes people don't wear them. And if you have gaps in the data, that really messes up a cycle-based forecast, as it turns out. So you gotta have like continuous data, which is very hard. Even for people with RNS, they gotta download all the time. So lots of problems with this. So we said, you know what, we need to do something that's maybe a little bit better, or at least is different. And so that's the last thing I'm going to tell you today, which is what we call snapshot seizure forecasting. Okay, and this is very hot off the press. So, this is also not a perfectly fleshed out problem, but I want to tell you what we did because it's very different. So we took 15 people who had RNS, and all of these people had their RNS electrodes, remember 2 electrodes, in each hippocampus. Hippocampus, most famous structure in epilepsy. That's a memory structure. That's where most seizures come from in adults with focal epilepsy. So every person had an electrode in each hippocampus. And we had all the data from them that we've been talking about this whole time. We had sparks, we had seizures, we had cycles, we had all of that. Okay, so we talked about how seizure risk fluctuates cyclically, right? So the purple line in the polar plot there, that's seizure risk, and you can see it's kind of skewed out on the rising phase. If I unravel that, so instead of on a cycle, I kind of stretch it out over 2 cycles, you can see the seizure risk going up and down, okay? Now, we look at what is happening in the brain activity as seizure risk is going up and down. And this is what's happening. It turns out it is not random. It is actually an orchestrated sequence of events, and I'm going to try and explain what that is. So red and blue here refer to communication either within a hippocampus, so the brain cells are talking mostly to each other within a hippocampus, and blue means they're talking to the other hippocampus, so across to the other side of the brain. And what I see, and the y-axis here is different frequencies of that communication. So what I see is that as seizure risk is going up and down, there's local connectivity and long-range communication. Local communication, long-range communication. It's like a neural heartbeat, almost, like that's just kind of going like this in concert with fluctuations of seizure risk cycles. Why does that matter? That matters because I can tell you what the communication pattern is at any given moment with a very small amount of EEG. I don't need months of baseline data. You show me a little snapshot of EEG, and I'll tell you how the hippocampi are communicating at that moment. That is very useful. So I'm going to draw a cartoon to explain why this is very useful, okay? So what we want to know is where you are in your cycle. Why? Because that tells me how likely you are to have a seizure. So that's what I really want to know is where are you in your cycle? But I don't want to monitor you for months and months. I want to do it quickly. So if I had something that I knew tracked with these cycles, like this shark, for example, and I said, well, I'm going to try and figure out what phase of your cycle you're at, but I'm only going to show you a little snapshot of that shark. I'm going to show you this. Where are we in the cycle? And you would say, oh, well, that's easy. You must be right there, because that's where the shark looks like that. And if I said, well, let me show you a different snapshot, this one, you'd say, oh, yeah, you're obviously at a really different phase because the shark looks like that over there. So even from a brief glimpse of that shark, you would know where I am on my cycle. So that's what we did. So we said, let's take really brief clips of EEG, 90 seconds, which are stored by the device. Let's take each clip and look at how the hippocampi are communicating in that clip and infer what phase of the cycle they must be in, and then issue a 24-hour seizure risk forecast. And we'll do that for every single clip. That's it. There's no characterizing cycles because this pattern, this shark, is very consistent across people. So I'll just take one snapshot, figure out what phase they must be in, and based on that phase, I'll tell you what their seizure risk is. Would that even work? I don't know. Well, it does. It works actually even a little bit better than cycle-based methods, and there's a variety of reasons why that might be the case. But it's definitely not worse, and I would say it has many advantages because now I need a single 90-second recording, and I can tell you what your 24-hour likelihood of a seizure is. I don't need months of baseline recording. So we think that's pretty nifty. it turns out that it's good for both sides of the coin. So one is, what is my chance of having a seizure tomorrow? So it's a little bit better than cycle-based methods for that. This is just showing a circular representation of that, but essentially blue is our snapshot model, and that's bigger than gold, which is the cycle-based model. And also, the other thing that's important to know is, it's almost more important to know, am I not going to have a seizure tomorrow? I want to also be very sure of that. That is helpful for planning activities and so forth. Is also very good for that. So we call this snapshot seizure forecasting. 24-hour seizure forecasts for which the input is a single 90-second record from RNS. Now, this also is not perfect because we are still using data from an invasive device, right? This is still intracranial EEG. This is still probably not scalable to like every single person. It's not practical to imagine everybody's going to get an RNS if they want a seizure forecast. But this is discovery. What we have found, we think, is that there are communication patterns that ebb and flow in the brain. And what that communication pattern looks like at any moment is related to what the momentary seizure risk is. And so it may not be necessary to measure people for long periods of time to issue a reliable 24-hour seizure forecast. So what do we do next? Lots of things. Let's go back to our current clinical paradigm where you go in, describe your seizures, and previously we issued sort of a static treatment, but now we understand, oh, actually seizures are not totally random. They're associated with cycles, and rather than bathe somebody in medicine the same way every single day, maybe we give them more medicine or other therapies when they're at highest risk of a seizure and less when they're at lower risk. That's what we call chronotherapy. Maybe we could communicate these forecasts back to people. We've built this app that we call MeteoMind, again, borrowed from paying homage to our meteorology friends. MeteoMind is an app that will be free that you can download on your phone that hopefully will be able to be a vehicle for us to deliver a seizure forecast to you so that you could wake up in the morning, fire up your app, and see what the risk of a seizure might be that day. How are we going to know if we're accurate or not? Well, we have to do the study. So we have just started, actually just last month, a trial that we call Eclipse. This is epilepsy cycles, longitudinal monitoring to inform personalized seizure risk estimation. That's a mouthful. That's why we call it Eclipse. Okay, so this is a prospective seizure forecasting trial. We have 20 people. They all have RNS. And what they're going to do is they're going to download their data every night. And overnight, our algorithms are going to churn away on the data and issue a seizure forecast based on all the methods that we've talked about. And when the person wakes up in the morning, they'll fire up their MeteoMind app, see their seizure risk forecast for that day, and actually to unlock that forecast, we're going to ask them for their own forecast, what they think is going to happen that day. So why? Because many people say, I think I know when it's going to be a bad day, right? And honestly, many people are right. Some people do have the ability to kind of know when their seizures are going to occur. So we figured if we're not at least as good as a person's own estimation, then what good is our model, right? So we have to first know what they think, and then we'll tell them what we think. And then we'll see what happens. We'll see if they actually have seizures or not. And along the way, we're going to be asking them a lot of questions, like, what is the minimum seizure probability that's actionable? Like if I said there's a 67.5% chance of a seizure, what should you do? Should you change something? Is that high enough? I mean, you have 99%, fair enough. But is that meaningful? Is this helpful at all? Will this just make people very anxious? And because it's never going to say 0% chance of a seizure. So you're never in the clear. Is this going to be helpful? Are there going to be medical legal issues? If I say, oh, there's a 6% chance of a seizure and somebody goes out and something unpleasant happens, what does that mean? 6% of the time, you could have a seizure. So this is a brave new world. There has never been a way to do this, and so there's a lot of fundamental questions that remain to be explored. But we look forward to learning from the folks who are enrolled in this trial. They are really pioneers. They're going to be teaching us about all of these things, and maybe next year I'll come back and tell you all about what we found. So I'll wrap up with a couple of take-homes, and I'm happy to field a few questions. We looked at how seizure unpredictability is disabling. We talked about history and attempts to explain seizure timing. It's not the moon. Okay. We talked about chronic EEG and the cyclical nature of epilepsy. Hopefully you're convinced. We looked at how those cycles operate over many timescales. They're organized through daily, multidian, and circannual chronotypes. We looked at how you can forecast seizures, sometimes days in advance, using cycles. We then looked at a newer approach that we call FC-based or snapshot seizure forecasting that has some advantages over cycle-based methods. And then there's so much left to do, like prospective clinical trials and trying to get some of this information less invasively than with an RNS device to make it more practical and more scalable. I'm going to stop there. We have an awesome team at UCSF who have helped with all of these things, and this is really, honestly, the tip of the iceberg in terms of what's cooking at UCSF. So if you have interest or questions, please feel free to come up to me afterwards. My colleague, Dr. Kleen, is in the audience too. We're happy to chat about stuff anytime. Okay, thanks for your attention. Question. That could not have been totally clear. Somebody has a question. There, thank you. Great question. I'm going to repeat the question in case people here didn't hear. It's a great question, which is really a question about scalability. So we talked about how maybe it's not practical for everybody to have RNS, to have access to this kind of forecast information. What are we doing to make it more accessible? And it's a great question. What I can imagine is, well, let's think about the easiest, least invasive, most accessible thing, which is scalp EEG. Many different ways to get scalp EEG, conventional scalp EEG, headband EEG, headset EEG. What if we did a study where, now that we know that we need just snapshots of brain waves, could we do a study where we measure scalp EEG non-invasively for a couple minutes, look at connectivity patterns on scalp recordings, and see whether those also portend seizures in the same way? I think it will be tricky. It's probably not going to be as good as intracranial EEG, but maybe there's signal there. Maybe we can augment the precision of that signal with data from wearable sensors and whatnot, so to make this totally non-invasive. That has to be the goal, because it's the only practical way. But it's a great question. Yeah. Thanks for that question. The question was, when we look at communication within or between hippocampi, what is that actually like? What does that look like? How does that work? I didn't get into the weeds too much. What we are looking at actually is a measure called functional connectivity, and it is a measure of, it is a phase coherence metric, which really means you can think of it as, in a given frequency range of interest, how sort of in sync are the brain waves coming from two different regions. And you can imagine that two hippocampi are doing their own thing and chattering away separately, or you can imagine that they're sort of talking in unison a little bit more. So I would not connote it as good or bad activity. I would just say it's different modes of activity. It would be like a room where everybody's kind of chattering and talking and having independent conversations, versus if we're all singing in a chorus. You can imagine that's a little more coherent, right? It would sound different. I wouldn't say one is better or worse. I would just say it would sound very different. So it seems that the hippocampi oscillate through modes where the way that they talk to each other and within each other, it changes. So it'd be like a room going from disorganized, independent conversations to us occasionally all speaking in unison and then fragmenting again. Imagine if we just kind of did that, right? So it seems that, at least for these brain regions that we've looked at, again, in a small study, it seems that's how this works. Please. Oh, good. Yeah, I can tell. Good. Yeah, good question. It can be any of those. What we looked at is phase coherence. Yeah, good question. You and then you over there.
Something pretty similar to the talk that I heard from Dr. Weill regarding using crowdsourcing machine learning to models.
Yes. Yeah, so the question was about a lot of work, and I showed that one slide about the 50-year history of seizure prediction. A lot of that was some of the more recent studies in that slide were actually studies of crowdsourced seizure prediction contests, actually. There was a Kaggle competition where they took a very famous data set called the NeuroVista data set, and they kind of scrambled it all up and said, build an algorithm that can distinguish periods of EEG that immediately precede seizures or that are in between seizures. Can you train a model to do that? And people use deep learning and all kinds of other fancy algorithms, and some of them performed very, very well on that data set. That is more a classification problem, where I give you a section of EEG and you tell me, is that right before a seizure or is that nowhere near a seizure? This is more probabilistic risk estimation over some longer horizon. It's a slightly different problem, but it's very informed by that fundamental work from all the seizure prediction literature. So you're very correct about that. Yeah, thanks for the correct question.
So is RNS the only way to catch that signal between the right and left hippocampus with a scalp EEG catch the same thing with the...
Yeah, I think you're reading my mind. I mean, RNS is probably the best way we can do that now because it's an FDA-approved technology. 6,000 people have it. We commonly put electrodes in the hippocampus. It was a convenience thing for us. It was just like, well, we may as well use this data that we are seeing every single day. But is that the only way? No. I don't think so. I think there are other devices that can do that. Some are investigational. There are scalp EEG and subscalp EEG, which is kind of an implant, so it is invasive, but not as invasive as intracranial. But the signals look awfully like intracranial EEG sometimes. So there's a lot of hope for less invasive devices that can provide similar information. It's just that currently we have a glut of RNS data, and it is so good for this, we may as well use it. But long term, we have to think more broadly. Awesome. Thanks for your attention. Guys, I'll hang out here if you have more questions.